So can you hear me? Does it sound all right?
I can hear you.
Okay, sounds
Are you
good.
Jan?
Hey, yeah, I'm Jan.
Hi, Jan and Hildy. Good to see you.
Well, it was a little touch and go here for a while. I had an upgrade on my computer this morning and I didn't have Zoom. So, um, yeah.
I feel your pain. I literally just had a Microsoft update and it shut me out of everything. And so I'm like, I was in a panic mode. But so that's why I'm joining early because I'm like, I just want to get on in case I get something weird happens. So I'm glad it worked so far.
Can let's see, no, I am on the wrong. I need, no, I don't think that's right either. Can you say something?
Yeah, testing,
Oh,
testing.
oh, there we go. Perfect. And is your last name pronounced Cohen?
Yes.
Okay, thanks. Oh, no, now I lost my list when I had to restart. So hold on. Well, we might as well start. I don't have my map to go by, so I'll let you introduce yourselves just for a little bit of housekeeping. Put your name and credentials and facility name in the chat box so that we can keep track of to see who is in attendance. As part of the participation in this echo session, we ask that you have your cameras turned on in order to make a more engaging practice. And remember to mute yourself when you're not speaking. If you have a question, you can shut off the audio mute button and ask your question, or you can write it in the chat and I'll help answer it, ask the questions for you. I will share the link to the pre-test questions as soon as I'm able to get into the share drive. I had an upgrade on my computer and I apologize. It's not, everything's running really slow and I don't have access for some things, but I'll work on it once you start. So if you want to introduce yourselves, you can start and I'll put in the pre-test questions as soon as I get them in the chat.
Okay, hi everyone. Can you all see my screen? Okay. Okay, perfect. Well, thank you for having us. We'll do some quick intros to start things off. So I'm Katie Gallant. I'm a senior research associate at NORC at the University of Chicago, and I'll pass things to Hildy.
Thanks, Katie. Hi, everyone. I'm Hildy Cohen. I'm a senior research director at NORC. Back to you.
Perfect. And sorry, I actually just had an update that was pushed to my computer right before jumping on. And so I'm hoping everything is okay right now, but just you may have to bear with me for a second if something does start getting a little funky. But let's try to jump in. So Hildy and I are both part of two suicide prevention projects that are in North Dakota. So we have the ND Thrives project and the ND Hopes project, and both are partnerships between the University of North Dakota and NORC at the University of Chicago. So to start, ND Thrives is a 5-year SAMHSA-funded suicide prevention project for youth ages 10 to 24. There's also an additional focus on reaching rural and tribal youth. And we have statewide activities as part of this project, despite an initial focus on North Central and part of Northeastern North Dakota. And then ND Hopes is our other project. So it's a 5-year CDC-funded suicide prevention grant for all ages with an additional focus on youth, veterans, and rural residents. We initially were focused in Western North Dakota, but we also have statewide activities for that project as well. And then across both of these grants, we provide training and technical assistance and evaluation to schools, healthcare settings, and community-based organizations. And we have our websites on the screen, so if you're interested in learning more, you can visit those websites. And if there is anything in the chat that I'm missing, I don't have the chat up right now, but please feel free to interrupt at any point and let me know. So we have a few learning objectives. By the end of today's training, you will be able to summarize rates of substance use in North Dakota, identify validated substance use screening tools, and describe how to conduct a brief negotiated interview. Okay, so we'll start with a little bit of background about substance use in the state. So we want to highlight a few different statistics about high school students in North Dakota. This data comes from the 2023 Youth Risk Behavior Survey that's administered in both middle schools and high schools. And according to this survey, almost half of high school students ever drank alcohol, almost a quarter had ever used marijuana, and nearly a fifth currently drank alcohol. And then, in addition, about 12% of high school students reported having ridden in a car with someone who had been drinking, and about 10% engaged in binge drinking behaviors. So, why is this important to know? Knowing about rates of substance use among youth is important because substance use is a risk factor for suicide. So, among North Dakota youth in the past year, those who currently use alcohol were 4 times as likely to attempt suicide, and those who used marijuana were 6 times as likely to attempt. In North Dakota, also the rural rate of overdose death is higher than the urban rate. North Dakota is one of only a few states actually with this discrepancy. Most states either don't have any significant difference between urban and rural rates, or it's urban areas that typically have higher overdose death rates. So now we're going to get into a bit about SBIRT. So that is screening, brief intervention, and referral to treatment for substance use. SAMHSA defines SBIRT as a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk of developing these disorders. And so, put a little bit more simply, SBIRT is an evidence-based practice used to identify, reduce, and prevent any use of alcohol, tobacco, drugs, and other substances. And the SBIRT model has 4 steps, as you can see on the screen. So there's screening, brief intervention, referral to treatment, and follow-up and monitoring. And we'll go through each of these components today. Before we begin with screening, though, it's important to understand the lower risk drink limits that we have in the US. And so this is according to the 2020 to 2025 dietary guidelines for Americans. So those state that adults of legal drinking age can either choose not to drink or to drink in moderation, which they define as no more than 2 drinks per day or 14 drinks per week for men under the age of 65, and no more than 1 drink per day or 7 drinks per week for women as well as men over the age of 65. And evidence suggests that drinking above these recommended limits can increase the risk for physical and mental health concerns, as well as make existing conditions worse. In the United States, a standard drink contains about 0.6 fluid ounces or 14 grams of pure alcohol. And so all of those drinks pictured are different sizes, but they each contain approximately the same amount of alcohol and count as a single standard drink. So it can be helpful to have a chart like this available when you're talking with someone about their alcohol use so that everyone's on the same page as what one drink actually entails. And so I'm curious what you all think about this. How many US adults do you think abstain from drinking completely? You can either unmute or pop it in the chat box. We're seeing a few different answers. Looks like mostly B, 12%. Couple more people responding. So it's actually 38% of US adults don't drink at all, which I think is always a bit surprising to people that it's that high. There was a recent study that was done, though, that surveyed people, and only about 62% of people in the US do drink alcohol. So it's definitely fewer people than most people expect. Thank you for Thanks for participating in that. We'll have a couple of different checks like that throughout this presentation. So there's also different substance use risk zones that I'll go through quickly. There's those people who are at lower risk. These are people who either don't drink completely, so that approximately 40% of people, or individuals who drink no more than 3 standard drinks a day. And so that's about 75% of the population falls within the lower risk zones. Then about 10% is in the risky substance use zone. These are people who exceed the recommended limits. And then there are those who have harmful substance use. This is another 10% of the population. And these are people who experience negative health effects or social consequences from their alcohol or substance use. And then finally, there are those who have high risk substance use. This is about 5% of the population. And those are the ones who would benefit from further assessment and referral to treatment. There's also certain groups who it's recommended that they don't drink at all. And so those are people who are pregnant, are under 21, people with health conditions that may worsen with alcohol use, and people who are taking medication that interact negatively with alcohol. Okay, so gone over the drinking guidelines and patterns of risk. So now we can talk about how to screen patients for substance use. Screening, most simply, is the process of assessing for risk. And screening should include assessing risk for a broad range of different substances. So alcohol, tobacco, marijuana, vaping, illegal drugs, and non-medical use of prescription medications. It should include the quantity, frequency, and consequences of substance use. Most validated screening tools are brief. They can be administered in under 5 minutes, and they can be verbally administered by a staff member, a provider, or self-administered using paper and pencil or something like a tablet. So today I'm going to go through the following screening tools. We have the audit, which is the Alcohol Use Disorders Identification Test. This looks at alcohol use. And then the DAST, which is the Drug Abuse Screening Test, which is 10 items assessing drug use. And then the CRAFT 2.1 plus N, which is a screening tool for youth, alcohol, drug, and tobacco use. So starting with the audit, this is a really simple and effective screening method for unhealthy alcohol use. It's recommended for adolescents ages 14 and above, but it has been validated down to ages 12 and up. The first 3 questions that you see here are referred to as the audit C, and the C stands for consumption. This This is the pre-screening questions for the full audit. So it's very brief, takes less than a minute to administer. You'll want to read the instructions and questions directly as they're written. And then the responses to each of these are scored 0 through 4. Once you've completed this, you would tally the points for each of the questions to generate a total score, and that will range from 0 to 12. And a score of 1 for adolescents is a positive screen, and a score of 4 for men under 65, and 3 for women and men over 65 indicates a positive screen and an increased risk for alcohol-related problems. And so if people do screen positive on the audit C, then you would ask the remaining 7 questions that are part of the full audit. And this is the full audit. And so while the audit C asks about consumption of alcohol use, the next 7 questions identify negative consequences of alcohol use and the likelihood of having an alcohol use disorder. Even though it's 10 questions total, it still is brief. It can be administered in about 1 to 2 minutes. And again, each of these questions are scored 0 through 4, with the exception of questions 9 and 10, which have possible responses of 0, 2, and 4. And so then again, you would tally the points for each of these questions based on how they respond to generate a total score. And the score ranges are from 0 to a total of 40 points. So when we think about scoring and the interpretation of the score, it's a little bit different for adolescents versus adults. But for those who are ages 14 to 18 years old, a cutoff score of 2 suggests potentially problematic use of alcohol, and a cutoff score of 3 suggests a potential alcohol use disorder. Other studies, though, suggest that for adolescents ages 13 to 19, a cutoff score of 4 or more would indicate a possible SUD. But for any youth who is scoring really above a 3, you would want to make sure to be following up with them with further assessment. And these are just ranges of scores. They can help guide the level of brief intervention that you'll provide and help you to assess the possible need for more treatment for them. And so, as you can see, a 0 to 1 is considered low risk. A score of 2 for youth is moderate risk, potential harm from substance use. And then a score of 3 or more indicates high risk and possible alcohol dependence. For adults or those ages 18 and up, an audit score of 8 or above would indicate risky, harmful, or potentially hazardous drinking. And so the ranges are a little bit different for adults. Low risk is considered 0 to 7. Moderate risk would be 8 to 19. And then high risk and a possible alcohol dependence is 20 to 40. And it's important to note that if someone scores a 10, that's not necessarily better than if someone scores an 11 or a 12, because both of these scores fall within the moderate risk range for alcohol. And so the individual audit score is not as important as determining the overall level of risk that someone would fall into. And as you likely know, many cases are more complex than a single screening score can really capture. And so you're encouraged to, as always, use your clinical judgment to evaluate if you think someone needs further assessment, especially if someone is on the cusp of any of these score ranges. Okay, so next we'll be talking about the DAST, the drug abuse screening test. This assesses drug use, not including alcohol or tobacco, in the past 12 months. It's recommended for ages 16 and up, and these first 2 pre-screener questions are known as the DAST-2. A possible response to each question is just either yes or no, where a yes is scored a 1 and a no is scored as a 0. If someone scores 1 or more on the DAST-2, then you would ask the remaining questions that are part of the DAST-10. So this is the full DAST-10. Again, all of these are yes or no questions. So you are just tallying up the number of yes responses, which are scored a 1, and no responses are scored a 0, with the exception of this tricky third question where it's actually reverse scored, where no would be scored as a 1. And so you would just add the number of yes or no responses to get the total score on the DAST-10. And so this is what the scoring and interpretation looks like for the DAST. And so you can see the risk level and the suggested actions that are associated with each range of scores. And so if someone is scoring between a 1 and a 2, that's a low level of risk. 3 and 5 is moderate level. 6 to 8 is substantial risk. And then 9 to 10 is severe level of risk. And for anyone who scores in the moderate level or above, we would recommend providing a brief intervention in the hopes of potentially connecting someone with treatment if that's appropriate, which Hildy will be going through in just a couple minutes. Okay, so lastly, we want to talk about the CRAFT. And the CRAFT family of tools have been extensively validated, and they're the most popular substance use screening tools for adolescents ages 12 through 21. This tool is designed to ask age-appropriate questions about problems related to alcohol, drug use, nicotine use, and it also screens for lifetime substance use disorder risk. And the CRAFT 2.1 plus N, a bit of a long name. So this is the one we're covering today, though, and it includes a revised, improved version of the original CRAFT, and it has an additional checklist about nicotine use. So prior to administering any version of the CRAFT, you would begin by saying what's written there at the top of the CRAFT. You can say, I'm going to ask you a few questions that I ask all my patients. We ask that you please be honest, and I will keep your answers confidential. And then you're going to ask all of the questions of part A on the CRAFT there at the top, exactly how they're written. And part A assesses for days of use in the past year for alcohol, marijuana, any other substance they've used to get high, and then vaping nicotine. And so that's part A. And then the questions in part A are actually not scored, but they indicate which questions of part B that you're going to ask. So you either will ask only the first question, the car question, if they answer 0 days within part A, or if they report 1 or more days on any question in part A, you would ask all 6 of those questions within part B. So it's a little bit more complicated than the audit or DAST, but it does have guidance right on the screening tool also to help guide you in that. And so the 6 questions of part B actually create the CRAFT acronym, which can make it a little bit easier to remember. And so C stands for car. Have you ever ridden in a car driven by someone who was high or had been using alcohol or drugs? R is, do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Then, do you ever use alcohol or drugs while you're by yourself or alone? F is, do you ever forget things you did while using alcohol or drugs? The next F is, do your family or friends ever tell you should cut down on your drinking or drug use? And then T is, have you ever gotten into trouble while you were using alcohol or drugs? So that's part B of the CRAFT. Then if you want to further assess the use of nicotine and tobacco products who are reporting 1 or more days on item 4 in part A of the CRAFT, this version contains the hooked on nicotine checklist, which you can see here. If you're not interested though in further assessment, you can just stop after part B of the CRAFT. And then some quick scoring and interpretation. So each yes answer for any question in part B scores 1 point, and each no answer doesn't score any points. And so you would tally the points that are accrued in only part B to obtain a final score. And so a score of 0 to 1 is low risk, a score of 2 to 6 is considered high risk, and a score of 5 to 6 is considered very high risk. And so, as you can see, this can help you to determine what next steps you would take with a youth who is scoring on the craft. I'll mention though that screening tools don't provide a definitive answer on if someone has a substance use disorder or not. Clinical judgment and other information is really important to take into account rather than just solely the screening score. And so, with that in mind, what do you think the primary purpose of conducting substance use screening is to do? You can pop it in the chat or feel free to unmute. Seeing some responses in the chat that look like a D. So this might be a little bit of a trick question. It's actually B. The primary purpose of conducting the screening is to simply determine the level of suicide risk or of substance use risk someone has. It can guide in determining what the next steps may be, but screening shouldn't be used to diagnose someone with a substance use disorder. I know that's a little bit of a tricky question though. Okay, so we also have a case example of Jimmy who we're going to go through. We don't have time necessarily to do breakout groups, but we want you to keep in mind this example of Jimmy throughout the rest of the training. So I'll just read this quickly. Your name is Jimmy. You're a 16-year-old high school student. You've been struggling in school lately and are currently at risk of failing 3 classes. You know that your teacher has contacted your parents about performing poorly. You feel like you can't do anything right. You drink with your friends because that helps you to not think about what would happen if you failed the classes. If someone asked you about your drinking, you might say something like, I don't think I need to stop drinking. I only have a couple shots of vodka or maybe a beer or 2. I try not to drive when I've been drinking. So keep that in mind. We don't have time to role play right now, but we would encourage you to, if you're interested in practicing, to pull up a version of the craft, which was in the handouts. It was sent around yesterday, and think about Jimmy and how you would respond to the craft based on that story. Okay. Any questions before we move on about screening for substance use? I think we'll also have a few minutes at the end if anyone wants to consider some questions. And I'll pass it to Hildy to keep moving along.
Great. Thanks, Katie. All right, now we'll dive into the brief intervention. This, as a reminder, is that second step in the SBIRT model, and it's conducted with individuals who've been identified at increased risk of having a substance use disorder or having issues related to their substance use based upon the screening results. So those individuals who screened positive, those are the individuals we do a brief intervention with. And before we dive into the steps of the brief intervention, I'll give a few definitions. We can look at the next slide. Just to make sure we're on the same page, because many of you may have already had some training on brief intervention and or motivational interviewing strategies. So the definitions we use are here. A BI, or brief intervention, is a behavioral change strategy, short in duration and aimed at helping a person reduce or stop a problematic behavior. BIs are organized around motivational interviewing skills. And motivational interviewing is that interviewing strategy and a communication method that's focused on the client's concerns, their perspective, and works to enhance their internal desire to change. So the core MI skills you may be familiar with are those ORs, or asking open-ended questions, giving affirmations, reflective listening, and summarizing what you hear. So MI is very person-centered. It helps bring in this approach that it emphasizes the patient and client's autonomy in an empathetic and person-centered way. So it's definitely all this BI is about meeting the patient and client where they're at. So if screening indicates at-risk substance use, then you will engage in a quick brief intervention. That's why we call it brief, that it can be very effective. So BIs typically include discussion around the points you see here, how their level of use compares to national averages, maybe bringing up some concerns about the potential consequences or effects of their use, talking with them about their goals, about what they want to commit to in terms of any changes around their use. And a BI, as you can see, can take as little as, I'll say, even 3 to 5 minutes, or can stretch over even longer sessions or multiple sessions. And that is part of the conversation and using your clinical judgment to see where the client's at and what might be the appropriate intervention for them. So the BI includes 4 steps, as you can see here. And we use the model that is called the brief negotiated interview. It's a structured interviewing approach, and it can help and encourage the patient to come up with an action plan that works for them. The BNI was originally developed for use in emergency departments, but it has expanded to be used in a wide variety of settings that many of you are probably part of, including community-based organizations, schools, healthcare settings. But we'll cover these steps today. And as we do, just as Katie let us in, we'll keep Jimmy's as the patient's scenario in mind. So Jimmy did score a 4 on the craft, which is that moderate risk, or it's considered high risk, and a BI is indicated. So we're going to move ahead with a BI with Jimmy, and perhaps referral to treatment or other services. And Jimmy reported on the craft that he was drinking about once a week, and answered yes to the riding in a car question, either riding in a car with someone who had been drinking, or using themselves. And Jimmy also indicated using alcohol to relax and forgetting things while drinking and getting into some trouble. So that's our case scenario as we move into the steps of the brief intervention. So the first step is raising the subject. This step helps you build that rapport with the client and patient. This is vital to the brief intervention. It shows that you're interested in getting to know the client better. You're interested in what's important to them in their life. So it's not just about talking about that screening score or diving into that score, but building some rapport with them. A part of that building rapport does mean you lead in with making sure the client is informed, especially youth, that everything you talk about would be confidential except if mandatory reporting is required. So you can see some sample language on the left around that. After you talk about confidentiality and maybe hear a few things about what they're excited about their life, then you'll open the conversation about asking permission to talk about their screening scores and their alcohol or substance use. Asking permission really brings the conversation into respecting their autonomy. It starts it in that manner, and clients and patients really respond to that. So you'll make sure, especially youth, know that this is a dialogue. So you'll ask that permission. Can we talk a little bit about your screening results? Please feel free to ask me questions at any time. And if you do receive any pushback or resistance, then you can add in normalizing this conversation. So saying something like, we ask all our clients about alcohol and substance use. We actually think of it as a vital sign, similar to taking your blood pressure. Oftentimes that will make them feel much more comfortable about talking with you. So you've raised the subject. Step 2 is providing feedback. There's a lot of components to this step, which are listed on the slide, But essentially, this step is about providing educational feedback on potential impacts of substance use for a patient. It gets them thinking about what might be happening with their use. So we'll go over a few techniques around providing feedback. So you'll review the screening results. For an adolescent who completed the craft, like Jimmy, you'll say, you can say something like, Jimmy, you mentioned in our screening that you drink about once a week with friends. And you said you rode in a car with someone who was drinking. Does that sound right? So during this conversation, if you do learn more about their use, you can always adjust the screening tool to make it as accurate as possible. And you'll want to, like you see here on the right, express concern about the use. So you can say something like, as your provider, I want you to know that I care about your health and I'm concerned about your drinking and or substance use. Would you mind if I provided you with some feedback? And if you get that, go ahead. You'll see here for adolescents and young adults under 21, it's recommended no use of alcohol and substances. And that is in particular because substance use during adolescence, as you may know, has the potential to impact brain development and increase the risk of developing substance use disorders later on in their life. Sharing this information has shown to resonate with adolescents and young adults. And so you can say something like what is pictured on the right. For adolescents and young adults, there's no safe amount of alcohol or marijuana use, especially because your brain is still developing until you're about 25 years old. There's a lot we don't know about, in particular, marijuana, but what we do know is that it can affect a person's mood, motivation, school performance, and lung health. As your provider, I recommend no use of alcohol or other substances because I want what is best for your health. That's an example of what you can say. The feedback step can be used to share other important educational information, like we mentioned earlier on, maybe comparing to national averages or calling out that certainly not the majority of youth actually also don't use alcohol. You can also bring in a discussion about not riding in a car with someone who was using substances. After you give some initial feedback, express your concern, you'll always want to end this step, like all other steps, with eliciting a response, getting some feedback. What are your thoughts about what I've shared? What reactions do you have? And again, this is sometimes the first time anyone's talking with a young person about their use. And so they're really giving them a space to share what's coming up for them is really important. Okay, so after you've went through the results of the screening, you've given a little feedback, it's now time to talk with your patient about their motivation to change, their motivation um, to make any modifications to their use or think about that. So there's a couple techniques that actually do enhance that motivation to change, and this is the magic. I've been working in SBIRT for over 10 years, and I'm always amazed at the conversations when we bring in a readiness ruler, and you'll see some pros and cons, but it really inspires me to hear the patients talk about, oh yeah, I didn't really think about how this is impacting my life. So the readiness ruler. So you can use it by beginning to ask your patient about their readiness to make a change in their substance use. So you see some sample language on the left. So you can lead in by saying here, the readiness ruler is a simple 0 to 10 scale we use to determine your readiness to make a change around your substance use, with 0 being not ready at all and 10 being completely ready. And then, a pocket card is in your handouts that does have the readiness ruler on it, so you can take a look, but you'll allow the client to choose a number and then ask them why they chose that number and not a lower number. And it's really important to ask it that way because by asking why they didn't choose a lower number, you're getting them to enhance that change talk in themselves. Like, oh yeah, I chose a 6. And you can say, you chose a 6, that's great. That means you're 60% ready to make a change. What made you choose a 6 and not a lower number like a 1 or 2? And asking it that way, it allows the client to think, oh, I really did choose a 6 and not a 1 or 2. Let me think about why that is. All right. Okay. However, all right, then after you have done some enhancing of the motivation to change in step 3, you're ready to talk about negotiating an action plan. And this is really working with a client. It's client-centered to see what feels realistic and attainable for them. So we'll look at a few conversation starters around this. So you'll elicit a response by asking an open-ended question like, what are your thoughts about our conversation today and what we've talked about? You can continue on by talking with them about what steps they're interested in taking to make a change. If they don't have any ideas, or if it's kind of difficult, they're struggling with what might be right for them, you can suggest some ideas such as a trial period of no use or cutting down on the number of drinks they would drink at a certain encounter. Again, for Jimmy, not driving, not riding in a car or driving with anyone that has used substances would be a good goal. And when negotiating an action plan, you'll encourage the client to set concrete, really specific goals and next steps. And some might just simply be paying attention more if they don't have any thoughts about making any changes. Might be just monitoring and considering how it affects their life. And then you as the clinician would check back with them at a certain time point to follow up. So you'll help them, you'll talk with them about what changes they might be interested in, and then work on developing that plan. You'll want to talk through what might hinder them, what might be challenging, any help you can provide in buffering those challenges, and maybe inspiring them to think about, if you make these changes, how would things be better for you? That can also enhance motivation. So at the end of this step, you'll summarize and review what you talked about. So we have an example, could be, so your plan, Jimmy, is to cut down the number of drinks you have at your parties with friends. So it would just be 1 drink at a party. And then you'll switch to drinking water or another beverage that's non-alcoholic. We've also discussed some possible challenges in that and ideas for how you plan to address them. So you'll reiterate the plan, and with adolescents and young adults and many adults as well, it's really helpful if they write down their action plan. That way they're writing it, they're internalizing it, and then they see it in their own handwriting, and they can use it as a reminder tool when they're thinking about the change that they committed to make. The last really important pieces of this step 4 are to arrange for follow-up and or referral to treatment or a higher level of care or specialized care if needed. So the follow-up plan definitely depends on that risk level from their screening score and from the conversation. So those at higher risk, a referral for further assessment and or treatment is warranted. For those at low to moderate risk, a follow-up visit should be scheduled to check in about their plan and progress towards reaching their goals. And of course, as Katie had mentioned, many cases are complex, involving both substance use and other mental health concerns. So a referral for further assessment might be recommended as well with other departments or other groups. And as always, it is your clinical judgment in working with your client and seeing their full picture. That kind of leads what you do after the BI. So you'll want to schedule a check-in, even if it's a quick call in a few weeks, to discuss how their plan is going, and then thank them for their willingness to have the conversation. This is oftentimes very difficult for anyone to talk about their substance use, and especially if there might be some negative consequences coming up. So it really helps give a youth especially confidence that you're a trusted adult for them. You can have that conversation. You thank them for being open today. Okay. So yeah, as a reminder, here's the case example for Jimmy, and you can use the pocket card, which is, we have a screenshot on the next slide, to practice after this. If you want to practice with a colleague, you can take your pocket card, get some reminders here on the left of some sample dialogue to use, and go through the brief intervention. Any questions about the brief negotiated interview before we do the final steps? Okay, great. Then, as you can see, the final steps are referral to treatment and follow-up and monitoring that we'll cover briefly. So during this step, when indicated, you'll provide a warm handoff and referral to higher level of care for substance use and or any mental health treatment. And additionally, you'll be wanting to follow up with the referral source to make sure the individual made it to their appointments and that they're progressing as needed. So a few definitions to just, again, make sure we're on the same page with the terminology, but referral to treatment and follow-up, we can talk about is linking the client to a specialized SUD treatment and or any other services, resources, supports, and regularly checking in to make sure and to facilitate sustained success. So referral to treatment means connecting the client to a licensed substance use professional or mental health professional or a primary care provider, can be to any of those, to further assess their need for additional care. It's also an opportunity to connect clients to other resources and supports as needed. And follow-up, we talk about as meaning providing care management and care coordination according to the provider organization's protocols, as well as supporting the adolescent during treatment and post-treatment follow-up contacts. Follow-up in the form of brief contact is appropriate for everyone. And I like to always say that we think SBIRT should really be called SBIRTs, because it's referral to treatment and services and the follow-up component. So it's definitely a broad range of not only treatment, but other supportive services and resources that we connect clients to at this stage. Who should be referred to treatment? So those who score at high risk, those experiencing negative and serious consequences of their substance use, and those who are unsuccessful in reducing or abstaining on their own. As you can see on the right box, it may be advisable, again, for complex cases with co-occurring medical and or mental health concerns with substance use, to think about more intensive treatment options. And then here are the most common settings in which substance use treatment occurs. You can see the outpatient, intensive outpatient, most commonly offered for those with less severe substance use disorder and those that have that supportive home environment where they can come back. They can go to a program and come back. Partial residential suggested for clients with more severe SUDs, but can safely manage living in their home while attending the program. And then residential inpatient treatment is recommended for clients with that severe level of substance use and really needs a 24-hour structured environment. as you may know, there are many different approaches and um, treatment therapies for those with substance use disorders. And one or more treatment options might be the right hybrid, is what I'm trying to say. A hybrid approach might be the best approach. Um, so there's also in the second bullet here, medication for the treatment of substance use disorders has proven effective with adults, but not all are FDA approved for adolescents. So this is something, if medication is a possibility for your client, to talk closely with the provider about some options. And on the right here, we have just a list of some common approaches and therapeutic models that you may be familiar with. So lastly, unfortunately, as you all, I'm sure know, there are many barriers to seeking treatment, both internal and societal, and maybe relationships and community related. And in fact, a 2019 SAMHSA survey found that nearly 40% of people aged 12 or older with a past year substance use disorder who didn't receive treatment at any specialty facility, they didn't perceive a need for treatment because they weren't ready to stop using substances. And 24% didn't know where to go to get treatment. 21% didn't have health care coverage and couldn't afford it. So many different reasons that a person might not be able to engage in further levels of care. So having knowledgeable clinicians there to help navigate these barriers can be very supportive and helpful. As mentioned, if the client is not ready, that is a big barrier. If they're not interested in treatment, rather than push them and jeopardize that relationship, it's important to accept and respect their decision in a non-judgmental manner. They may be more willing to accept that notion of treatment during future sessions if you can do multiple brief interventions or just as you follow up and check in with them. And so that's why scheduling that follow-up conversation is really, really important, because also that initial conversation could ignite thoughts and of change, as well as they're thinking about their substance use in a whole different way and may need a little bit of time. So a follow-up conversation is really important. Okay, and then lastly, around scheduling services, if, for example, Jimmy is amenable to further services and or treatment, then it's important to coordinate with a care provider and share information, of course, with a signed release of information. So on the slide here are just some tips for referring to another care provider to ensure that care is effective and consistent. And so many clinicians will keep a list of providers that they work with. You'll want to send a written report and check in with that provider on how things are going, and then keep the report brief and neutral, including simple things such as date, name, date of birth, their contact information, and any other relevant information, so that the provider that you're referring to has a brief overview and can begin that relationship. So we'll end with a brief knowledge check here. In which scenario would you refer someone to treatment? And pop in the chat what you're thinking. One response. Come in. All right, thank you, Brave, for being brave. Actually, we can show this one is A and C only. So referring to treatment when they're experiencing that withdrawal symptoms, so that's the clear one. And when they report daily drinking, yeah, those are the key ones that you'd want to refer, certainly. All right. And then thinking back to Jimmy, would you refer Jimmy to treatment or not? Yes or no? In the interest of time, we can pop up. Yes, Jimmy would benefit from referral to treatment or others and or services. Here's some, yes, thank you. Thanks everyone. Here's some of the reasons why they report, they score that 4, which is the high risk category, and are having some effects of it on their life. All right, well, we'll wrap up with just a couple minutes. I'll open it up for any questions. And on the following slide, we do have some resources that are linked in the PDF of the deck that you got. So you can take a look if you'd like some more information, but any questions before we close?
I'm going to post the post-test and the evaluation. And if you don't have time to do it right now, copy the links and then just do them. And also I'm going to put in a link that for some upcoming pediatric mental health sessions that we have coming up.
Thank you all so much for having us.
Well, thank you, both Katie and Hildy. This was very informative. I appreciate all the information. And thank you all for attending this session today too. And hope to see you all at the next pediatric mental health session. Thank you.
Thank you all.
I also apologize for the inconvenience to start with my computer.
No, not at all. We're just happy ours worked too, because yes, and there was a poorly timed update that we had as well. So
Well, and then my internet went down right in the middle of this, so I hope it didn't affect any of you, but we'll see. So,
nope, all good. Well, thanks everyone. Feel free to
thank you.
send us any
All
questions as
right.
they come up. Take care.
Okay, bye now.